afternoon. We are the Dream Team. I'm Isabella Aukis.
I'm Gio Gamelga.
And I'm Rachel Yang.
And our coach is Dr. Ari Hoffman, a hospitalist at UCSF Parnassus. And together we worked on improving inpatient sleep on 14 Long. And first of all, we would just like to thank everyone who contributed to this work and made it possible. We could not have done it without all of these people. So studies have shown that short-term sleep deprivation has significant negative consequences, especially for patients in the hospital. It can increase cortisol, weaken immunity, and lead to difficulty healing for our patients. Literature shows that the average inpatient has about 5 hours of sleep a night. Here at UCSF, our inpatients have about 5 hours of uninterrupted time at night, meaning they probably get even less sleep. Notably, medicine patients who had less than 4 hours of sleep at night had nearly doubled the risk of developing delirium the very next day. Based on prior student work and interviews with care teams on 14 Long, we discovered that our inpatients are often disrupted unnecessarily at night for various reasons. These include environmental factors such as alarms and lights, and provider interruptions. At Parnassus, patient vital sign interruptions at night have largely been addressed by way of introducing sleep-promoting vitals so that patients who are stable are not interrupted for vital sign checks between the hours of 10 p.m. and 6 a.m. However, we noticed that even patients on sleep-promoting vitals who are supposed to be stable were still getting interrupted 2 separate times a night for medication administrations. So our target goal was to reduce this by 20% for patients on sleep-promoting vitals.
So one of the first things we wanted to investigate was what medications were being administered at night to these patients who are on sleep-promoting vitals. And as we could see from this Pareto chart of the 10 medications administered the most to these patients, we could see that insulin and acetaminophen account for about 25% of all nighttime medication administrations. And initially, we wanted to target both of these medications in our intervention. However, our discussions with UCSF's endocrinology team taught us that there are safety concerns associated with changing the scheduling for insulin. And so we came to the conclusion that acetaminophen would be the safest and easiest target for intervention. In addition to that, we also conducted a gap analysis that looked into what factors contributed to medications being administered at night. And through our discussions with nurses, pharmacists, and physicians, we were able to identify 3 major contributing factors that we needed to address in order to make a change. The first factor we identified was the culture. Sleep-promoting vitals is typically associated with vital signs only and not necessarily medication orders. The next factor we identified is the care team. Physicians have ordering habits that makes medication administrations fall at certain times of the day, and sometimes these can fall at night. In addition to that, there's also a lack of awareness among providers about differences in medication order timings and how these might impact our patients' sleep. And the last factor we identified was the system. Our electronic health records have defaults that encourages medications to be administered at night. And so, for our first experiment, we wanted to address the system factor by changing the default for acetaminophen, which was originally Q6. Under the original default, patients would be woken up at midnight in order to receive this medication. And so, through our collaboration with pharmacists, we were able to change that default into Q8 in order to promote patient sleep.
So along with our EHR change, we also engaged in this very fun educational campaign that was mainly targeted towards ordering providers. We wanted to emphasize and really increase the awareness of appropriately timed medications. And we really prioritized order sets that naturally fall during daytime hours. In addition, our team worked on announcing our efforts and really promoting our meetings at hospital medicine staff meetings. So after those interventions, here are our results. We found that we didn't move the needle too much on total nighttime medication interruptions. It stayed around 2 medications per night. So as a result of that, we actually conducted a more granular analysis on just acetaminophen. And we found that Q6, nighttime acetaminophen, did decrease over time, which we believe is due to our main EHR default change that rolled out in late December. So in terms of lessons learned, based on the impact of this default change, we recognize how valuable it can be to really leverage the EHR for behavioral change. Furthermore, this is a pretty complex, multifactorial problem that we really tackle as an interprofessional team, our dream team. We talked a lot about with nurses on 14 long on sleep promoting practices, and talked with pharmacists as well on the clinical safety of changing within benefit and defaults. Lastly, we also targeted multiple pillars for behavioral change, including enabling and predisposing factors. And in the future, we really hope to engage in more reinforcing factors as well in terms of audit and feedback in the future. So thank you for listening, and we're open to answering any questions.